All right.
Oh, I think Teva asked. Sorry, Teva asked to share the link, but I would. I'll put in the WhatsApp group. Just ask them to enter the meeting ID and also the password.
Yeah,
It's
yeah.
okay. I
Key
think
in
you can
the
confirm.
ID and password. Yeah. All right. So I'll just continue, right? About absent contractility again, right? What the conclusive will be what is being listed here, right? Normal IRP, 100% failed peristalsis. If the IRP is the upper limit of normal, suspect achalasia, right? Where you need to do a time barium esophagogram, and also, uh, sorry, I just want to admit everyone in. There are still some in the waiting room. All right. So you need to rule out achalasia with a barium swallow or time barium esophagogram and endo flip, right, if it's available. Okay. So now coming to the next diagnosis, right, which is distal esophageal spasm. So the criteria is still the same, right? Less than 4.5-second distal latency. The only thing is that here you have majority of the DES pattern, right, likely representing a secondary response to reflux, right, in patients with GERD. So that is something to consider when you see a DES. So the diagnosis could be anti-reflux as well, right? And the other thing to note is sometimes patients could be taking opioids for many reasons, and that could also lead to a DES pattern, right? So if you see a distal esophageal spasm pattern, always think of opioid, always think of reflux in your differential diagnosis, right? So conclusive means basically you have all the criteria listed here, right? Median IRP normal, more than 20% swallow premature, right? Meaning spastic. What can happen sometimes in inconclusive situations is if you have a normal IRP, but we have 20% swallows with distal latency, less, but also on top of that, the DCI is also reduced. So sometimes that can make you think of right whether it's IEM as well, right, present here. So what to do in this type of situation, right? Sometimes to support your diagnosis, right? You can do a time barium esophagogram, right? And you sometimes can see the corkscrew pattern, right, which is seen in distal esophageal spasm, right? Or rosary bead pattern, right? Seen in the barium mid swallow. And of course, sometimes you can also do an endo flip, right? Sometimes what you can pick up is repetitive retrograde contractions or sustained occluding contractions, right, during response to the balloon distension. So how about hypercontractile esophagus, right? Actually, they have a few motility patterns meeting the definition, right? Hypercontractile could be jackhammer. It could be a single peak hypercontractile. Jackhammer is multi-peak contraction, right? So sometimes on top of that, you also get single peak contraction, more than 8,000 in DCI. And of course, sometimes what you get is also a hypercontractile swallow with a vigorous LES after contraction, right? So meaning the lower esophageal spasm has a prolonged contraction, right? Increasing the DCI reading. So sometimes all these situations can occur, right? So hypercontractile, all right, again, conclusive. The diagnosis requires a normal IRP with more than 20% or more of hypercontractile swallows, right? DCI more than 8,000. Sometimes what happens, you can get an inconclusive situation, right? The IRP normal, right? 20% or more hypercontractile swallow incidentally are identified on evaluation for reflux symptoms, right? So patients don't really have the dysphagia, or the patients don't really have chest pain, right? Because for Chicago 4, you need supportive symptoms, right? So to come to a conclusive diagnosis to support your diagnosis, right? So in the absence of symptoms, then you can do some supportive testing, right? So what you can do, right, right, is right, although the manometric definition suggests normal propagation and LES relaxation, right, sometimes you can look for EGJ obstruction evidence, spasm, right, abnormal bolus retention, or on esophagogram or endoflip, right, to help you to diagnose a hypercontractile esophagus. right? So this is what I mean by distal esophageal spasm, right? The first diagram on the left, right? DCI is less than 8,000, but your distal latency is less than 4.5 seconds, right? And IRP is normal, 12, right? So this is DES, right? Of course, you need symptoms to be present as well to diagnose it. And for hypercontractile, right? So these are the few patterns that we do see sometimes when we are doing merometry. So like in the single peak hypercontractile swallow, right? So the DCI will be more than 8,000, but it's just a single one. This is compared to jackhammer, right? So last time we used to think that jackhammer is just based on DCI, but actually now they're divided into three different types of hypercontractile esophagus. So you get a single peak, you get a multi-peak, right? As shown in the third diagram here, right? Which is suggestive of jackhammer esophagus. And also the hypercontractile lower esophageal sphincter, right? Sometimes we do see this type of pattern as well, right? So the hypercontractile portion is just at the LES region, right? And or very near to the EGJ region, right? So this area is hypercontractile, right? The rest of the contraction looks quite normal, but when you total up the DCI, it will be more than 8,000, yeah? So these are the three recognized patterns for hypercontractile esophagus. So coming to ineffective esophageal motility. So the only difference between IEM currently and the previous one is that they are more stringent in the criteria of diagnosis, right? So from previously at least 50%, now it becomes 70%, right? So they have tightened the conditions, right, for IEM. And on top of that as well, you need symptoms to be present, right? And if available, then supportive evidence from a barium swallow or right, showing a poor bolus transit, right? And of course, they included the provocative testing criteria, which is multiple rapid swallow, something which we have been doing all this while, right, in USM, right, to demonstrate a lack of contractile reserve, right, present in these patients. So conclusive diagnosis more than 70%, right, which can be either fragmented or weak, all right. And so basically inconclusive sometimes when you get 50 to 70%. So these are the patients where they satisfy Chicago 3.0 criteria for ineffective esophageal motility, but now no longer right satisfies the Chicago 4 criteria. So you need further supportive testing to come up with a diagnosis of IEM, right? So poor bolus transit on impedance. So a lot of times if assuming we are not using the water perfuse systems, all right, the old water perfuse system. So if you are using a solid state system, then we can look at the bolus transit, right, and decide based on impedance, right, whether there's bolus clearance or bolus retention, right. So in patients with bolus retention and ineffective esophageal motility, 50 to 70%, then it may point towards IEM diagnosis, right, in those with inconclusive diagnosis. Of course, you could also do a barium swallow, again showing poor barium clearance. And of course, the provocative test to be done is the multiple rapid swallow, right? Showing poor contractile reserve, meaning the DCI ratio, all right, is less than 1, right, on MRS compared to the average of the 10 saline swallows. So this is what I mean by absent contractility, right? The first diagram, you don't see anything at all, right? Hardly any contraction activity. IRP is normal, right? But again, in your mind, if in this example, IRP is very normal, right? 6.8. But if you get a upper limit of normal, always think of early achalasia, all right? For ineffective esophageal swallow, right, where the DCI is less than 450, right, but still more than 100, right? Meaning it's not really failed peristalsis, it's just weak peristalsis, right? So this is the pattern seen here, right? Where the IRP is normal and the DCI is still within the weak peristalsis range, right? So another pattern of ineffective esophageal swallow is fragmented peristalsis, right? So the definition for fragmented peristalsis remains the same, right? 5 centimeters, right? So you have to be more than 5 centimeters. So in this example, it's 6.1, right? The separation, right? So this is considered as fragmented peristalsis. And DCI is normal, but it's fragmented, right? So it's also ineffective, right? But you need to have 70% of these patterns present, right? Or more, before more than 70%, right? To diagnose, right? IEM here. And this is what I mean by DC and multiple rapid swallow, right? So after 2 cc saline swallows, right? Usually the peristalsis will be augmented. So you get a DCI ratio that is usually in the normal patients will be more than 1, right? Showing preserved contractile reserve. On top of that, you can see that during the 5 rapid swallows, the IRP actually drops, right? So showing that there is significant LES relaxation. And on top of that as well, there is absence of any contractile activity when the multiple rapid swallows were done, right? And that actually shows intact deglutitive inhibition reflex, right? In these patients. The normal one should appear like this, yeah? So coming to the last part, which is EGJ metrics, right? So this is an example showing you basically Chicago basically 4.0 actually incorporated EGJ metrics, right? Which is not present previously to define hiatus hernia, right? So basically they did a few things, right? And that although there's no standardized definition for the pattern or EGJ complex, right? Type 1, type 2, of course, we are familiar with the EGJ type 1 being normal, type 2, and type 3, 3A and 3B, right? Over here, they didn't really mention anything except for the position of the respiratory inversion point in relation to the crural diaphragm, right? So I'll show you the subtype of the morphology first, right? So basically, here in the upper left quadrant, right, you can see the dotted line here is the respiratory inversion pressure, right, or the pressure inversion point, right? So during inspiration and expiration, so in a normal situation, then it will be together, right? Which is together, showing that the diaphragm and the lower esophageal sphincter is both together. And what we have in B is actually there's a bit of separation, right? So usually we consider this as the EGJ morphology type 2, right? So basically you have the partial separation of the LES and the crural diaphragm. And in type 3, basically the only difference between type 3A and 3B is basically the position of the respiratory inversion point in relation to the crural diaphragm, right? So the pressure inversion point, right, in 3A is actually slightly higher than the crural diaphragm, but below the LES, right? In type 3B, the respiratory inversion point is at the level slightly above the LES, right? Proximal to the LES. Okay. So, but this is just one of the example of the way they classify it, right? They haven't standardized the way to classify EGJ morphology at the moment, right? So at the moment, it's just one example to show you, right? And on top of that, they did mention something about EGJ CI, right? Which is EGJ contractile integral, something like DCI, but it happens over the EGJ region. Some of the systems allow us to measure it, but at the moment, they haven't really defined the significance of EGJ-CI yet at the moment. So for example, we have gone through some of the data that we have done in USM, and at the moment, we couldn't really demonstrate that patients with reflux, right, have a lower EGJ-CI compared to, so at the moment, it's still not, they are not very certain about the significance of EGJ-CI at the moment. And perhaps in Chicago 5, they may incorporate it with more data later on, right? So this is what I'm talking about. And this is the end of my talk. Now we'll be opening the floor for questioning.
Hi. Yeah, thank you very much, Phei, for a very comprehensive cover of Chicago 4. For those who are doing motility, we all know that Chicago 4 is the holy grail for diagnosis of all these various motility disorders. I would just want to highlight a few points, especially for those who are actively practicing motility in their units. One is that the protocol, also depending on what system that you have, whether they are water perfused or solid state. Although most of the units nowadays, they are already moving towards the solid state type of catheters. And if you are already using solid state, it might as well do the we tend to do the upright position already, isn't it, right? In which case, if you were to do an upright, and if you were to find at the end, you mentioned, I think when Pei mentioned here, they do suggest to do a rapid drink challenge. So some of us may not be familiar with this, then I think it's time to sort of like incorporate this particular provocative test into our protocol, right? Other than MRS. I mean, in our unit, we've been doing MRS for all patients, and we are starting to also incorporate rapid drink challenge. So I think for this particular Chicago classification, they emphasize on using certain provocative tests to support some of these inconclusive findings, so to speak. All right. So I think it's quite important to incorporate those into our protocol now. But as for pharmacological intervention, to be honest, I think not all units would have amyl nitrate or even cholecystokinin. So I wouldn't, in fact, in our own unit, we don't use them at all. So it's really up to your unit if you really want to use, cholecystokinin or amyl nitrate. But certainly in our case, we don't use it. We do use a provocation. So maybe one of these day, Pei On would like to, do another meeting like this just to share what kind of a provocative test that we are doing, and they are really useful. We have recently presented a case where he has a non-cardiac chest pain. We diagnosed as EJJ outflow obstruction. We have dilated him before. And then on follow-up after about 2 years, he came back with another chest pain. And now we found out that he also have hypercontractile esophagus only after provocation. So this is just one of the cases that illustrate how provocative tests would be helpful, right? You want to add anything else, Pei On, at this
And
point for the protocol?
yeah, probably like what Prof said, it's true. Provocative test is actually very useful, and it could be an adjunct that to help you to diagnose and differentiate between different conditions. So yeah, it's definitely very useful if units doing esophageal manometry can incorporate it inside their protocol. Yeah.
Yeah. So one more point to note is that opiates, right? I think in
Yeah.
our protocol, and also making sure that that your patients are not taking any opiates before the manometry testing. And if of those of us who have been doing manometry or motility testing, we know that a EJJ outflow obstruction can be a very common disorder other than ineffective esophageal motility. These are the two most common motility disorder that we commonly encounter, right? And some patients with so-called EJJ outflow obstruction may be a result of opiates that your patient are taking. Now, opiate can also appear in some of these traditional medications, your cough syrups, right? So traditional herbs, for example, although I don't have any conclusive evidence, but certainly it may be possible that some of your patients who have EJJ outflow obstruction may be because of the use of opiates. I think another important point to take note in our protocol is, of course, when you are doing a positioning change, supine to say upright, always bear in mind that the positioning will have an effect on your so-called Chicago matrix. So I would again encourage you to read on even we do have produced a paper for the Malaysian uh, matrix. If you were to do from a spine to a upright position. It was published in Journal of Gastroenterology and Hepatology. I would certainly encourage you to read that paper and that would be the normal t-value that you can use for our own local population, right? Okay, I think that's probably all for the protocol. And again, if you notice this, for Chicago 4, they did not mention anything about upper esophageal sphincter or the pharyngeal, right? So we will not mention about that. But in our own unit, we do have protocol for evaluation of UES and also the pharyngeal complex. Another aspect of yeah, I think that's all for the protocol. I think we can move on to diagnosis, right? Now, for diagnosis, what I noticed is that now, like what Peo has mentioned, they have what they term as clinically relevant conclusive diagnosis, conclusive manometric diagnosis, and inconclusive diagnosis, and then supportive testing. So this is I think something new, certainly not mentioned in any previous classification before. And I do think that this is a very positive, development, because many of sometimes when we are even doing provocative testing, we must always remember to ask for symptoms, right? So if during the provocative testing you found a hypercontractile peristalsis, and also along with symptoms, I think that will be more clinically relevant, isn't it, right? So that will be one. Always correlate between symptoms and your manometric findings. Now, for inconclusive diagnosis, I suppose, again, this is for those who are doing a lot of mobility tests, then you start to appreciate certain a feature that doesn't fit into the classical definition of the metrics. And these are the ones that really needs supportive testing, including provocative testing, as well as the use of a barium esophagogram and or endoflip. Now in Malaysia, we don't actually have an endoflip, right? So we tend to depend on a barium esophagogram. And for even barium esophagogram, your radiological department, they don't do a time barium. This is something that I think different hospitals need to discuss with their radiologists on doing a time barium rather than just a normal barium esophagogram. I think Peon has illustrated early on that that there is a differences between the time barium when you evaluate the 1 minute and the 5 minutes. Okay, so that would be what I would mention about diagnosis. Is there anything you want to add, Pay on?
I think that's about it, Prof. Yeah.
Yeah, of course, I also welcome any Q and any question from the rest. Maybe my last point is that about the yeah. So the other part I think is on the ineffective esophageal motility. This is also another very common disorder that we encounter, right, in our motility practice. Now, we tend to classify IEM under minor disorder and the hypercontractile disorder, and also DES as the major disorders. Now, with IEM, if you notice, exactly like what Peon mentioned, it has changed from previously 50%, now it go up to 70% of ineffective swallows. So if just say you have swallows that are ineffective, like between 50% to 70%, that is one that again you might need to depend on some supportive testing. If your unit, the catheter has an impedance built in, then we can use a bolus transit to help us. So this is something that again, having an impedance on your catheter means a more expensive probe, right? But then it will provide you some useful information. And again, in Chicago 4, they only mention supportive testing. there are not a lot of data showing that how this bolus transit really helps. But in my own experience and a previous study that we have done, it does help us to differentiate um, so what I call as clinically significant swallows from clinically insignificant IEM. Now, unfortunately, I did not manage to publish that paper, but hopefully when there are time, then I'll probably want to publish that, or even repeat another study looking into how we can diagnose what I term as a clinically significant minor disorder, and how it can be differentiated with a non-clinically significant minor disorder, right? So I think very frequently we use a multi-rapid swallow to evaluate IEM, because what happened is that in someone who has ineffective motility and also abnormal multiple rapid swallows, these are the patients that might develop dysphagia after fundoplication. So it's very important that although the name is minor disorder, it may not be that minor if just say that is a lack of a contraction reserve, which means this patient, if you do a fundoplication, there's always a potential risk that they can develop a dysphagia. So I think there's a lot of unclear points also in Chicago. They are still not very clear about IEM, although they have sort of like, you know, um, have improved on it with some of this supportive testing and so on, but they are still not sure. In fact, you were to read at their recommendation, they have what they call as conditional recommendations, and so on and so forth. So meaning that they are not sure, right? They really need more research in order to support their what their conclusion here. So that's much about the IEM. And lastly, you are right about they have just introduced this metric of EGJCI. I think so far the Sains system or the Diversitech system, they do have a measurement of EGJCI, right? But no, I'm not really sure about MMS. I don't think it does. But then again, usually when the Chicago classification comes out like this, the companies are very quick in incorporating the changes into their software. So I would anticipate that in a year or in 1.5 year, there will be incorporation of this into their Chicago, into their system as well. So it's possible for Diversitech to also incorporate this. But for some reason, I think MS is so much faster in incorporating all these changes into the software. And I also surprised that why they did not include their the MMS metric for the IRP. I think it's very important to bear in mind that IRP can really be different between probes, right? So you need to know what is the acceptable upper range or upper limit of the IRP for your probe, right? So for MMS, certainly it's about 19. And for the Diversitech probe, it can be at 20. So when we say borderline high IRP, you need to know exactly what is the upper normal limit for that particular probe. Okay. Now maybe I can. No, I don't want to spend too much time on your evening. So, are there any questions from the floor, the participants? Now, just bear in mind, this is a non-sponsored. It's basically our own initiated talk. Okay, we have colleagues here from Big Pro, but they are not the ones supporting this CME, right?
Yeah.
Yeah, just a declaration of conflicts. And anyone to ask any questions? Yeah, more than happy to unmute, or you can even pull up in the chat group. If not, a yeah, if not, then we can in a way conclude the talk. But if you feel like you have any questions, you're more than welcome to put into our WhatsApp group, right? For those who have been previous trainees and fellows in our unit, then you certainly are there in the WhatsApp group. But if you are not and you like to ask questions, yeah, please convey to respective person or even email to one of us. Okay. If you do not have the paper, yeah, maybe you can also ask a pay on to share the paper,
Yeah,
right? Just in
I'll
case.
upload it into the WhatsApp group later on.
Yeah, thanks very much. And you make more sense if you were to able to compare with the previous version. Then you realize that what is the difference between previous one and the current one. Okay, if there are no other questions, I would say that is all. Yeah, I think I saw like Rona also inside, right? Or I think she probably left already. I think that's fine, no problem. Now for my own nurses, I think Azriani and also Siti, we might need to again discuss the relevance of this particular classification and how we might want to modify our protocol. But at the moment, I think we already covered like what we have been. I think in fact, I think the what has been presented in Chicago 4 has been what we practice so far, right? But there may be some minor changes that we want to modify for our own unit. Okay, I think that would be all. I thank you very much to everyone who has attended. There are some participants that I'm not very familiar with, but thank you so much for joining us. And hopefully, if there's any other similar talk, you're more than welcome to join us.
Yeah, Prof. Some of them
Am
are
I
from the
correct?
gastro unit in Ipoh.
Ah, I see.
Yeah, yeah.
Welcome. Thank you for joining. Well done. Okay. Thank you so much, Peon, again. For doing this. And I wish everyone a good evening and take care. In these very trying times of COVID-19. Thank you very much and stay safe.
Yeah.
Bye
Stay safe,
bye.
everyone. Bye bye.